In a neonate, the diagnosis, investigation, treatment, and prognosis constitute an approach. And you have to specially consider whether the child is premature, at term, or post-mature. Diagnosis always means site of lesion, nature of lesion, cause, effect, and association of lesion. Cause can be genetic, embryological, congenital, infection, immune reaction, or immune deficiency, neoplastic, degenerative, metabolic, paralytic, or miscellaneous. Besides this, it can be traumatic. Differential diagnoses are less probable diagnoses, stated in order of probability, higher to lower. CNS, CVS, respiration, GIT, hepatic, renal, blood, metabolism are the systems that are tested. So, suspect, prevent, detect, and manage sinister problems of the newborn. The first problem is prematurity. You have to deal with breathing, hypothermia, congenital anomalies, sepsis, jaundice, and problems identified by tandem mass spectrometry. RH incompatibility, you know from before. By Coombs test, you detect antibodies in mother by indirect Coombs test. The child's father is RH positive, mother is RH negative. And in fetal blood, you detect the cells that have been sensitized by direct Coombs test. You have to monitor bilirubin. Direct bilirubin rise with clay-colored stool and absent urobilinogen in urine indicates biliary obstruction, and which is much rarer as compared to RH incompatibility or physiological jaundice. Asphyxia neonatorum, the non-expanding lungs. You have to look for hydrocephalus, spinal dysraphism. That means spina bifida, occulta, meningocele, meningomyelocele associated with hydrocephalus is called as Arnold-Chiari malformation. If you have a blue baby, look at congenital heart disease or upper respiratory tract infection. Look at congenital hernias, tracheoesophageal fistula, congenital pyloric stenosis, achalasia cardia, congenital megacolon, imperforate anus, undescended testes, hypospadias, CDH, genorecurvatum, CTV. And on screening, you can detect hypothyroidism, hypoglycemia, jaundice, uremia, phenylketonuria, etc. After some time, look for sepsis, look for GI obstruction, look for anuria, seizures, fractures, or breaches in skin. Prematurity deals with, you have to deal with breathing, hypothermia, congenital anomalies, sepsis, jaundice, problems identified by TMS or tandem mass spectrometry, and all problems of a full-term baby, which are more frequent and severe in premature. Limited reserve in a premature child due to hypothermia, hypoglycemia, hypocalcemia is infection, anemia, jaundice prone. So, in the CNS, you can have head injury sustained during birth. You can have patent ductus arteriosus. That's the most common CVS abnormality. In GIT, you have to look for necrotizing enterocolitis, especially because of ischemia, sepsis, maternal cocaine, and top feed. So breast milk protects against necrotizing enterocolitis. Retinopathy in less than 1 kg is 80%, in 1 to 1.2 kg is about 65%. And this is called as retinopathy of prematurity or retrolental that means behind lens, fibroplasia, which means dilated tortuous vessels and fibrous tissue in vitreous, especially at the posterior pole. With traction, it can cause detachment of the retina. The gold standard is indirect ophthalmoscopy. Treatment is photocoagulation or cryocoagulation. And you have to keep following the child regularly at 2 weeks or 4 weeks, up to 30 weeks thereafter. Thereafter, the problem recedes. So on examination, you detect hydrocephalus, and with hydrocephalus and spinal dysraphism. This is called as Arnold-Chiari malformation. A blue baby with congenital heart disease, congenital hernia, tracheoesophageal fistula, going from above to downwards, congenital pyloric stenosis, achalasia cardiac, congenital megacolon, imperforate anus, undescended testes, hypospadias, CDH, genu recurvatum, CTEV, and limited joint movement because of arthrogryposis multiplex congenita. On screening, you detect hypothyroidism, hypoglycemia, jaundice, uremia, phenylketonuria, etc. Neonatal sepsis is infection of the newborn. It is late, that means greater than 72 hours. The bacteria enter through water, uncooked food, contaminated hands or breast, through mouth, nose, umbilicus, or injection. Hand wash practice is most effective prevention in ICU. The most common causes are nosocomial, that means coagulase positive staphylococcus or Klebsiella. Early maternal fever within 7 days of delivery. Pain in lower abdomen, foul smelling liquor due to group B streptococci. This predisposes for early neonatal sepsis. Now the incidence is falling due to gentamicin and ampicillin prophylaxis. Sepsis, the screen is the gold standard for early diagnosis. TLC less than 5,000 or greater than 2,000 indicates severe sepsis. Absolute neutrophil count of less than 1,500. Smear showing immature neutrophil with toxic granules. More than 20%. So this is ANC means neutrophil plus band cells. Micro ESR rises from less than 3 in first 3 days to more than 15 in first hour. The CRP or procalcitonin is positive. Lumbar puncture has CNS signs and neck rigidity in late sepsis. X-ray chest for pneumonia, blood culture and sensitivity. Antibiotics as per culture sensitivity to be given for bacteremia 2 weeks, meningitis 3 weeks, arthritis 4 weeks and osteomyelitis 5 weeks. The respiratory distress syndrome, which has a 30% mortality, cough, choking during or without feeding, a blue baby with or without crying, Krebs, fast labored, obstructed breathing. Asphyxia neonatorum, apnea is normal 20 seconds till 20 seconds after birth. If delayed, look for central cyanosis, bradycardia under 100, pulse rate. The cause can be central or obstructive. In premature, it is central. You have to stimulate respiration, especially in prematurity, which has central apnea almost 100% in less than 28 weeks of prematurity. Can occur within 1 to 2 days, but never after 7 days. Treatment is by caffeine citrate 20 mg per kilogram loading dose and 5 mg per kilogram maintenance. In obstructive apnea, tract should be cleared by suction tracheostomy. Bronchodilators may be used, aminophylline 5 to 6 mg per kilogram. oxygen, CPR, and ventilation. If there is repeated RDS, tracheoesophageal fistula has to be ruled out, especially in premature. If yes, operate and ligate the connection. Blood gases and electrolytes are monitored. X-ray chest to detect pneumonia. Culture sensitivity of aspirate to detect URTI. Antibiotic coverage as per culture sensitivity. Record Apgar score, which means appearance, pulse, grimace, activity, and respiration. All are scored. 0 means absent, 1 means subnormal, 2 means normal. And this has to be done at 1 minute and 5 minutes after birth to prognosticate. Monitoring has to be done at score below 7. Bronchopulmonary dysplasia, oxygen dependence after 4 weeks, needs home oxygen therapy. Choanal atresia, that means nose block. If bilateral, the baby will turn blue when feeding but will be pink while crying. So we are now starting to deal with GI obstruction. You see the superior constrictor and the cricopharyngeus. Between it, the mucosa can herniate, causing the Killian's diverticulum. So as the baby feeds, there is a swelling in the neck and there is dysphagia. On barium meal, there is the tea kettle appearance and this needs surgery. In tracheoesophageal fistula, the baby chokes during feeding and this needs surgery. If the baby vomits immediately after feed, barium swallow shows parrot beak appearance. It is a chalasia cardia, again needs surgery. If there is a projectile vomit after feeds, distended stomach clinically and radiologically. Non-bilious, non-gas, NG tube aspirate, left to right, visible paralysis, peristalsis in upper abdomen, palpable firm lump in hypogastrium against the vertebra. Diagnosis is pyloric stenosis, decompress. In the third part of duodenum, obstruction by supium-centric artery like pyloric stenosis. So everything is like pyloric stenosis except the nasogastric aspirate will yield bilious content. So you have to decompress or bypass by gastrojejunostomy. Absolute constipation, distended descending sigmoid colon in iliac fossa is called as congenital megacolon or Hirschsprung disease. So you have to resect the ganglionic segment or reanastomose. For the intermediate time, you may have to do a colonostomy. Same thing with the imperforate anus. A perrectal examination will reveal an imperforate anus. If there's obstructed hernia, volvulus intersusception, you have to explore and decompress. So you have to reduce, you have to resect if necessary, you have to bypass, or you have to reanastomose. Supportive treatment in GI obstruction, diagnose the level and cause, monitor vitals, blood gases and electrolytes, abdominal girth, intake output charting, bowel sounds, tenderness, fluid or air in abdomen. Perforation is indicated by a silent abdomen, board-like rigidity, masking of liver dullness, and air under diaphragm and sitting X-ray abdomen. Needs 4-quadrant suction, drainage, antibiotics according to culture sensitivity. Besides the monitoring, there is nothing by mouth, IV alimentation, nasogastric suction, flatus tube in place, and pre-anesthetic checkup for anesthesia and surgery, and post-operative care. Anuria. Note the duration of anuria by clinical history, examination, or investigation. Look at Fontanelli depression. Then you can think of prerenal uremia, like causes like dehydration, malnutrition, starvation, diarrhea, or vomiting, internal or external bleeding, or burn. All this is prerenal. Look for renal agenesis by ultrasound of the abdomen, and post-renal, see the purpose, palpate the penis and urethra, look, feel and percuss for bladder, look for kidney lumps. You have to correct the cause, clear the obstruction, dialysis in the intermediate period to maintain fluid and electrolyte balance. In the CNS, seizures point attention to the CNS, but if the child is non or under responsive to stimulus or listless, not taking feed, abnormal look, position, lack of movement of part or seizure. You have to look at the pupil size, symmetry and response to direct and consensual, cranial nerves, tone, withdrawal or movement on stimulation, neck rigidity, superficial and deep reflexes, anterior fontanelle, whether it is tense, bulging and not pulsatile. You have to suspect intracranial hemorrhage. This is intraventricular, 30% in less than 1500 gram babies, and in full term the cause can be breech or instrumental deliveries. There is never subarachnoid hemorrhage in such cases. Differential diagnosis of meningitis or encephalitis. There is increased risk of asphyxia, mental retardation, quadriplegia, developmental delay, and hydrocephalus. Localization, parasagittal injuries or marmovatus lead to spastic quadriplegia, which is developmental delay and mental retardation. Periventricular leukomalacia. Upper limbs are normal, lower limbs drag. Commando-like crawling. This is called a spastic diplegia. Investigation, ideal MRI, available USG through anterior fontanelle will reveal a intracranial space occupying lesion, which can be a hemorrhage. Differential diagnosis, meningitis, is neck rigidity, CSF cellularity, culture, proteins, counts, encephalitis, where counts are not usually raised. Hypoxic ischemic encephalopathy, you have the Sarnat staging, where everything, sensorium, tone, DTR, morose, pupil, seizure, and EEG are normal in the first grade, lethargic in the second, and coma and unresponsive in the third. The hypotension in premature can be caused by autonomous immaturity. PDA, the patent ductus arteriosus, connects the aorta to the pulmonary artery, leading to a pansystolic murmur and a blue baby due to reversal of shunt, where unoxygenated pulmonary artery blood goes into the aorta. It is a vessel wall defect due to preterm asphyxia, liberation of prostaglandins. Prostaglandin blockers like NSAID, brufen, ibuprofen, which is less nephrotoxic, and indomethacin are used. In full term, PDA is due to rubella. Treat it by banding, inserting coils, or ligation if conservative treatment fails. You can look for CTEV, CDH, myodystrophia fetalis, osteogenesis imperfecta, which means multiple maluniting, easily produced fractures with blue sclera, which are corrected by multiple corrective osteotomy and IM nail, which is called as the Sikh kebab operation. And you have to look for craniocledal dysostosis, where the sutures are not fused and the two ossific nuclei of clavicle are not fused. And we have already dealt with neonatal jaundice, and we'll have to deal with it in a separate lecture.